Dream machine. Diacom H07I18 in the snap. We're building the future, never looking back.
Welcome back to Imaging Informatics Unplugged, the show where we try to make sense of the ever-expanding world of imaging IT, one acronym and one AI model at a time. Today's guest is Dr. Mana Moassefi, an incoming radiology resident at the Mayo Clinic in Rochester, Minnesota. Mana serves as the vice chair of the Members in Training Committee at SIM and also serves on the Radiology Artificial Intelligence Trainee Editorial Board. Now, her research focuses on artificial intelligence in women's imaging, and in this episode, we dive into a multi-institutional study that she helped lead using large language models to extract diagnostic findings from radiology reports. Now, this is no small feat, especially when we consider that these reports are not exactly written in plain English. They're more like a choose-your-own-adventure novel co-authored by a thesaurus. But in this episode, we discuss prompt engineering, structured reporting, interinstitutional variability, and what happens when LLMs try to be helpful and instead they start improvising, like when they insist that there are only 2 R's in the word strawberry. Spoiler alert, there are 3 R's in the word strawberry. So if you're into AI imaging or you just want to hear more from someone that's shaping the future of radiology, you're in the right place. Don't forget to like, subscribe, and with all that said, let's jump into it. Welcome to Imaging Informatics Unplugged, and welcome, Mana. I'm very happy that you could be here today, and I'm looking forward to this conversation. We've chatted a little bit before SIM25, and I actually got to meet you in person at SIM25, and I saw an abstract that you presented in Portland, and I was wondering if maybe before we get into the conversation, if you could just, at a very high level, explain what was the abstract that you were presenting, what were you talking about, just for the audience?
Sure. Hello, Jason. Hello, everyone. I'm really happy to be here. Thank you so much for the invitation. I'm very excited for this conversation, actually. The abstract that I presented at SIM was actually a study that we have conducted with some work collaboration that was done under the SIM research committee. At research committee of SIM, we had a lot of PIs from different institutions, and that was actually we were lucky to have these people, each of them becoming an anchor in very big size medical institutions in the US, across the US. And we all decided to work on something to sort of prompt engineering and doing something multi-institutional without having all this legal and IRB struggles and all of that. So everything was done at the institution separately. And then we got the results, all of it together. It was like a little bit limiting. We could not do a lot of analysis between the institutions, but what we have done was that we selected a large language model. We engineered the prompts to extract the labels from radiology reports at each of these institutions for a number of diagnoses and extracting the information. And that was done at each of the centers.
And you're at Mayo. What were the other organizations that were participating in this?
I'm at Mayo Clinic. It was Moffitt Cancer Center. We had Harvard Med School and Mass General. UCSF was a part of it. Irvine, CI.
Okay, and so here you were using LLMs to identify or annotate radiology reports across all these different institutions.
Yes.
I remember from the abstract, you talked a bit about, you validated this against a few different LLMs. I'm curious if that was the approach right from the get-go, or did you think about using other traditional NLP models, or was it always going to be prompt engineering?
The other university that I missed, sorry, that was Emory. Oh. That would not allow me to sleep if I don't mention. That's a good question, actually. Comparing the NLPs and LLMs, we did not do any kind of training, to be honest. We used a large language model, just got it and used it. So there was no training happening here because they're very good in understanding the context and communication. These days, we communicate with LLMs, all of us, every day. So they're good in understanding it. And why we have not used NLP was that there is a variability Radiology reports are actually sort of narratives in some centers. Some centers, they have templates of radiology, but they have this structured templates that they use. With them, that's a little bit of difference here, but still people are putting words in those radiology reports. So it is like communication between me and you. Each person is saying each thing that they want to say in the way that they have. They have their own style. So with NLPs, we had this limitation of adaptability and understanding the variability of the context and how people are talking about it. It would be a little bit more keywording with NLPs. And we have LLMs. We had the infrastructure to use them. So decided why not? And we're not the only people doing it. It's studies, there have been a lot of studies trying to extract these labels out of radiology reports. To be honest, if I want to tell you about the inspiration of why we did what we did, you see this sentence in medical literature a lot, that medical information or medical data is rare. It's expensive, which is true. But the fact is that medical data, imaging at least, is not rare. We have millions of MRIs, we have millions of CT scans, but we have some problems with them. One is the storage, which with the upcoming hardware, that's not going to be a huge problem. But the other one is that we don't have curated labeled data. That's what is limiting us. But at the same time, healthcare spent millions of dollars to have reports beside these images. So we have reports, we have images. The only thing that is limiting us is bridging these two and finding a word, finding a class out of that report. And that's the whole inspiration and why we are trying, all of us, to a lot of different studies trying to extract this label out of that narrative. That's
Radiology has talked a lot about in the past about structuring the reporting, and there's been resistance against that. There's a lot of benefits that come out of structuring. I'm curious, of the participating organizations, did any of them have any kind of like maturity when it came to structured reporting?
They actually did. And it showed that with a structured reporting, we have a better chance of extracting better information or extracting information with higher accuracy. And we may even not need like a very complex large language model to do so. With templates, that's easier. For Moffitt Center, for example, we had that, and our accuracy is like close to perfect for extracting the information. But some of them, despite having the template, it showed that there are still radiologists putting their own style in the template. And even with that, we cannot work through it. You know, it's not a must. It's not like something definitely making us perfect, the templates, but it still helps in some centers. You cannot say it's a definite thing, but the resistance is huge against using this structured reporting.
And so of the LLMs that you were using, these are commercial off-the-shelf LLMs. They were not trained in any type of way. What were you using? What were the different models, and how many were you using for this study?
I think we were using 11 or 12 of them. We used GPT, a variant of GPTs, and also llamas. And our best model was, I think, Llama 3.1. At Mayo Clinic, we used all of them and figured which one is the best. And we used them using like prompt engineer instruct way, and also with some chat box. One of the things that was definite in our study was that this chat way of getting this information was failing way more than having a prompt and having an instruct. So chatbox was not great, and we ended up with having instruction-based prompt engineering, Llama 3.1. And at Mayo, we used all of them, and then we decided to pick one of them and went and asked the institutions to use that one and like run that one with the prompt that was also engineered at Mayo Clinic. They used that prompt. They used the same model at their own centers.
So let's go into detail about the prompt engineering part of this a bit. So what goes into engineering a prompt? Probably a lot of the people that are listening to this, they have used ChatGPT or some sort of, Claude or one of these. And what is the difference between approaching the LLM and just, randomly asking it questions versus an engineered prompt?
I think there's a lot of literature and trend outside saying that prompt engineering is important. But one thing that I want to say here is that, and one thing that I'm seeing a lot in literature is that for something like radiology report, which is not like a 10-page text. It's like a half a page text, and it has an impression actually with a lot of information in it. So it's a short text, not necessarily having a lot of medical knowledge needs to be behind it to extract the information out of it. With the prompt engineering, with putting some conditioning, adding some information, all of those things, adding that, and with the context window that we have right now with LLMs, this huge context window we have with GPT, with a lot of different models, and it's getting bigger and bigger. There are studies showing that we don't need a lot of RAG, we don't need fine tuning. With a good prompt engineering approaching these models, we can near perfectly extract the data out of the reports. And that part was one of the most interesting part of this study to me personally. And one of the other things that we figured out, so one thing was that prompt engineering was important. We didn't need a lot of fine tuning. And that's a trend that you see a lot in the literature as well. The other things that we approached was that some nature of the diagnosis, the nature of the information that you want to get out of the report is very important. For example, what we faced was that with fractures, we conditioned our model to say, okay, if we have C1, C2, this fracture, that's a cervical fracture. So answer that as yes. If there is a chronic or old fracture, say no. And we try to push our model to say yes or no, and not giving us an explanation. But we had another label like pneumonia. For pneumonia and fracture is a lot based on radiology to sort of diagnose it. But for pneumonia, they say it in a lot of words, radiologists. They said consolidation, opacity, this and that. We covered all of those things, but at the end, a lot of them say that you need to make sure that the clinical signs and symptoms are aligned with pneumonia. The nature of pneumonia was making our model less accurate because it could not figure out what should that be, Even the report was not that certain. So the uncertainty and the confidence level of radiologists for the nature of different labels that you want to get out of the report, that's something that was affecting our results very much. And that was another interesting part of it. The other thing I can tell you about prompt engineering was that we prompt engineered at Mayo, we actually got the better results at Moffitt, for example, for UCI. So it wasn't that prompt engineering somewhere would make it, the context and the way, the style, the templates, all of those things are affecting what you get out of the report way more than the prompt that is engineered, I think.
That's interesting. So that kind of leads into where my next question was going to go is you have a variety, even if there is structured reporting at these individual organizations, the templates are potentially going to be a little bit different, and there's going to be pros that radiologists always kind of find a way to fit into there. How it seems like, there was a variability on the effectiveness at one organization versus another organization. What do you attribute that to, the fact that how the report was or how the prompt was, how things were structured?
To be honest, one of the limitations of this study that we have not done, we could not share reports together. That was one of the limitations of this study. But we never figured out what is missing in one of the centers that is exactly why this is happening, that one center is responding way better. But we asked our PIs to check each of the centers and let us know what was the reason for failure. And I think the templates, the ones with templates were really better, but I don't have necessarily an answer to say that what was exactly coming into the styles of radiologists that was making one center better than the other. Still, we can say that was random, to be honest, because we call them this center, this center, this center, but still you see that people in the center are the ones that are making this difference, That person could be in another center and making that difference. So I don't have, per se, an answer to that, to say it as a fact or say it as a finding of our study, but I can tell you that templates were helping.
And so the volume of reports that were assessed, was it an even amount of reports across the organizations?
Yes, it was 500 at each institution as the test. And we had 6 institutions, so 3,000 total. But we got, interestingly, in no centers, in no diagnosis, like any of those labels, we got like less than 70% or 80%. Some of them we got close to 100%. So imagine that. All the data that we got, for example, this label for fracture, 100% accurate, got out of the report. So all the data at that center for that label is, useful for the future model training, for future of vision model training with label curated, that's a valuable data to have, really. I
Mhm.
cannot say medical data is rare anymore with this
So,
kind of thing coming up.
was there anything that, as you were approaching this and the results were coming back, that surprised you in any way?
I think the surprising thing was that one of the centers were using templates. They did not see the best results despite using the templates. Two of them that was using templates, and although they were not using templates for all of the different diagnoses, some sub-departments were using them, some not. So that was a little bit of difference. Some of them were using templates and that was not doing great. And we think that still having uncertainty and the confidence level of speaking up to that diagnosis was what was affecting that. That was the most surprising thing we saw. And the other surprising thing was that how good it is to how amazingly it's functioning. Because, in medicine in general, to be honest, Jason, when you face these labels, pathology, radiology, all of that, I personally worked on a disease, endometriosis disease I worked on. And I was working on radiologists reading positive or negative for endometriosis at a center, subspecialized radiologists. And the inter-rater variability of radiologists was super high, was really, really high. And I know that in a lot of fields, and even in pathology, that's high. So we can never say that the labels that we have are 100% perfect for what we are doing, but still getting it at this level of accuracy, at this level of efficiency, I think it's something, with what we see
Absolutely.
with human is not consistent. AI is at least consistent in making mistakes.
Yeah, it's interesting. Prasant, who co-hosts Simcast, he shared an article with me about when AI makes mistakes, it is so atypical to how we make mistakes. If you give me a calculus question and I get it wrong, it's likely that the next calculus question that I get given, I'm not going to do much better. Whereas AI can do amazing on one question and then completely off on the next time. How was hallucinations and these types of mistakes handled and that consistent nature of what you were seeing?
What was the biggest, the hallucination part existed actually at the level of we were trying to get a yes or no answer from AI. It was giving us a 2-paragraph explanation actually, with saying that this is it and explaining like things that was somehow irrelevant. So we decided to sort of discard and this sort of put all of those things as wrong answers. So what you see as the accuracy in our paper is the real yes or no's that we got, not explaining. For sure, right now, we are facing the hallucination, and we were facing hallucination in the response. We asked in our prompt to tell us yes or no, but at the same time, it was explaining it to me because that was uncertain or they could not figure out the response. So that exists. That's going to be something always that exists. I always say that some people hallucinate too, because we are inconsistent. One day I am like ups and downs in our minds affects us in many, many ways. But for AI, we want it to be standardized, to be better than what we do actually, to make sure
And
we're getting into something really. And also, if the mistake is, as you said, if it is like totally off, which happens sometimes with AI too, that's dangerous. That's for sure dangerous.
well, there's the classic one where you ask a model how many R's are there in the word strawberry. Have you ever seen this
No,
before?
no.
So try it afterwards, and you might get it might say the right response, which is 3. But many times it'll say 2, and it does this for Claude or ChatGPT, and it will argue with you about how there are only 2 R's in strawberry. And so it's interesting, like when it gets things wrong, it's so fundamentally off from how we logically put our answers together.
That's
Did
true.
you notice certain models were more prone to hallucinate than other ones, or was it generally consistent? When one would hallucinate on a certain prompt, you would find that the other model would perform similar, or what did you find?
We did not see an actual trend in each of them that we saw like this one is making, but we were seeing that with the chat boxes, we were seeing like weird answers, off answers, really off ones. But when we were prompting, and that was a little bit better than asking in a chat box and putting it into a chat box. I don't know what's with the nature of chat box that is making it like that more. Apparently, they are more focused on conversational talking things. I don't know exactly what it is with them, but that was, and I saw that in a lot of literature saying that chat boxes by nature are not great for extracting information. They're like a little bit differently trained. So that's something that
That's funny.
we figured out too.
The layer of conversation almost adds complexity to the way that it's responding, perhaps.
Exactly. And because they think that they can communicate with you, they are more willing to give you explanation rather than a definite answer. That's what it is in nature of chatbox.
Interesting. When you were playing around with the different models, you mentioned Olama. Did DeepSeek ever get considered as an opportunity?
No, we haven't done this DeepSeek one. Actually, that was a little bit done before that coming.
Oh, okay.
Before that becoming very trendy, yes. Because that took a lot of time for us to do this. At Mayo, it was like 6 months ago. More, even like 7 or 8 months ago. And then we shared it with different institutions, and then we could publish it. So it was a little bit before DeepSeek.
Currently, right now, the focus of your study was tagging and identifying the findings. But I see an opportunity where you could have this presented to perhaps in a patient portal, and the patient could be asking the LLM, provide me the diagnosis, or provide me, what does this mean? Or what were the findings in this report? And then it coming back with a lay explanation, a very common explanation for like a non-clinical person. Or, in organizations where you have unstructured content, being able to put things together in a more structured way and identifying it. So really like beyond the study use case and seeing other applications where this could be used for whatever.
Actually, that's an interesting idea. One thing that we need to be always careful with patient communication, especially, and also putting it in a non-scientific word, is that we make sure that we have all the data when we are talking to our patients. And that's what mostly doctors do when they're communicating. You have to get information from the clinical notes, all of those things. With that together, you see the patient actually, and then you talk about a fracture. It is possible to talk about one diagnosis out of this, for example, radiology reports. Imagine that I have this report. I say that, okay, if it is pneumonia positive, for example, give this kind of an explanation to my patient, avoid, for example, this contact, do this, do that, or if it is not, or if you are unsure, say this and that, keep them safe, we can make sure that our patients know things sooner. For example, this report, your report is out before you visit your doctor and get the definite, for example, diagnosis, as they do this, do this, do this. That's actually a very good use case that we can talk about it. But that's exactly the other thing that you mentioned is very important. And one of the nuances that I see that is happening here, there's the idea of this multi-agent models or agentic AI models that they have a lot of agents. And imagine that we have all of them, and then one of them would be working on extracting the diagnosis out of reports, one coming getting information out of clinical notes, one coming and talking about the certainty of what we see in the report. Actually, confidence and certainty is something that I'm mentioning a lot because that's very close to my heart, that part. We have all these reports and doctors say things, for example, this is possible. This is probable, and we don't have a standardized way for radiologists to tell us how sure they are. I'm 80% sure that it is, for example, pneumonia or a fracture. I say possible or probable or maybe, or, that's very vague. If we can have that, that's not a standardized. And we are having this uncertainty quantification models that we are trying to get the level of confidence, and we don't have a data to feed them. Because at best, we have the diagnosis, yes or no, but we don't have the level of certainty of radiology. And there's always, you see always in the reports that they say that this needs to be evaluated with the clinicals, or it is possible to have that, or give us 5 differential diagnoses, which one of them is true. putting this all together, I can tell you that there are going to be with this multi-agents, for example, one of them working on certainty, one in clinical, one in report, putting them all together, and they have this feedback loops that they give you a response, they can go back and work on themselves, improve themselves. That's something that they're working on, and it's going to be way better than there are a lot of what they call baby boomers that are aging right now. I think it's going to get better and better. But these are the steps that we need to take. Prompt engineering, doing multi-institutional, doing huge size data works, and then getting multi-agents coming in. There are going to be a lot of functions for patients, for educational purposes. I was thinking that as a radiology resident that I'm going to be, imagine I'm querying, for example, I want to know all the, for example, hip fracture label. I want to read different reports, a style of different reports of my, for example, professors at my center or other centers, and then see which style is the one that I want to choose, how educational that could be to me. So there are a lot of use cases, a lot of interesting things can come out of it. But the best one is labeled data for training more models.
So something you said, I'm curious what your thoughts are around transparency. So when we start looking at agentic AI and we start having these agents kind of running in the background, and when agents start speaking to each other, and we lose the sense of the cookie crumb trail of like, why did they decide this particular outcome? And maybe it's a really great outcome, but I'm curious what your thoughts are about how we capture the transparency on why a certain decision or outcome was the one that was presented?
This idea of transparency to me is like a little bit of, I think we need to be more open. I agree. There's sometimes they're not transparent. You don't understand how they got to the result. You get you doubt them a lot. And it's a rational doubt that we have to have, always staying a little bit necessarily not being optimistic about whatever they are giving us. I agree. We always need to stay that way, especially in healthcare, because when they make a mistake, that's awful. But one other way for us to work on that, because there are models right now, for example, radiogenomic models. We are now understanding the genomic information out of imaging, something that no human being could do, to be honest. And right now, we don't have an explanation of why that's happening, how that's happening, but that's being accurate. That's showing that in a lot of validation, it's showing that it's been accurate. So we cannot explain this. Is it like making that function irrelevant and we should not rely on that? I'm not sure. If validation is saying that this is like a huge size validation telling me that this is something that I can rely on, maybe I can rely on that. That's exactly, maybe I'm too optimistic.
Yeah.
All right. Maybe I don't know. I think we need to stay always keep the precautions always in the place. But if big size information results are good and we don't understand how they got to it, maybe that's another way of thinking. We are always trying to make AI think like humans and try to go to the path of me thinking, I would think it that way. Okay, maybe that's thinking another way and figuring it out. Maybe that's going to be better than me. That's actually the purpose of that AI in general, to become better than us. So why we are trying to make them articulate in a way that we want it to be articulated. That's my thing.
It's an interesting point because there's a book I recently read called Nexus, and it talks about AI really is alien to the way that we think. And we try kind of molding it to be kind of operate under the human paradigm of thinking, but it really is this alien way of thinking because it's not familiar to us. So we're at about the 30-minute mark. I like to keep these around this time. I wanted to just ask you before we close out. So you're a doctor and you're a radiology resident, and you're also very much into informatics. And I'm curious, what came first? Did you know that you wanted to be a doctor first, or were you always interested in kind of this informatics side? And what drew you to the AI interest?
I actually first decided to go to medical school at age of 18, to be honest. And so that was first medicine. But I was always interested in math and statistics. And also, like, when I learned about some concepts of AI, that was like, I was mesmerized with them. Like, all this different, the idea of backpropagation for me was so sweet to articulate something that way. It was so interesting to me, the whole deep learning at, I think it was 2017 or 18, sometime around that, or 19. So I started to look into it and found a way to put the data and coding, which was fun, really. At the time, it was so way more fun. You know, we were debugging for days and hitting our head to the wall to debug things. So, but at the time that was happening, it was like giving the whole world to you. It was so happy. So I had the joy of coding. I learned about coding. That was the joy of that, concepts of AI, and all the love I had for math and stats and putting them all together. I thought that radiology would be like giving me a lot of data to work on. Language models were not that big, to be honest, at the time that I got interested in radiology, but I think I'm very happy to work on, I am very happy to work on vision models, actually.
And what a time to be here doing this. Like, you mentioned back propagation. And
Yes.
so, like, that's from the 70s where I think it was Hinton and a couple other guys that had come up with the back propagation. But it's really like it had to sit in the attic for years because the compute power just didn't exist. And now here we are, you know, and now Hinton has kind of retracted his prediction of radiologists being the coyote that was running off the cliff. But it's a remarkable time because for so long, this was just theoretical and this was just math on chalkboards. And now here we are seeing it operational. It's very cool.
I don't want to make this very long, but there's one thing that I want to mention here about radiology and the deep learning and AI. A lot of people are worried about, in general, AI come in and taking over all what we do and all of these things. I have one comment about that, especially when you mentioned that thing. One thing is that might happen. I'm not like I cannot predict future. That might happen in future, but it's going to be a lot of shift in what we are doing in diagnosis to going to screening, to go into better screening. And I was listening to a podcast, and I don't remember who was saying that, but they were saying we are not in the level of perfect healthcare. You know, we are not in a level of perfect medicine. We are way, way far away from that, having a perfect treatment or cure or a lot of these things. And imagine having a tool that is helping us get closer to that. You know, look at it like this. We are constantly thinking, okay, I can do that with this capacity. AI is going to come and take that capacity from me. So imagine it's going even higher and we are the one leading it and going with it, you know, that's going to change the face of medicine. And I think it's going to be exciting, and we need to be a little bit more positive about it.
I like that. Yeah, the quote I often hear is AI might eventually take our job, but ultimately the people that take our jobs will be the person that uses AI. And so if you are a Luddite and refuse to embrace machine learning in any way, yes, you very likely will have a tough time proceeding in a career, whatever it is, whether it's in medicine or anything. And by the time we're at the point where we're replacing radiologists, we're going to be replacing lawyers, and the whole society will be different. And we're far from that, but it's time to get on board. And I agree with you, though. I think the future is bright when it comes to this stuff.
Yeah, that's true.
Well, thank you very much for taking the time. I'll give you a chance if you want to just provide any kind of closeout thoughts around your study or anything like that, and we can close out there.
No, it's not much that I want to say. Just one thing is that for doing multi-institutional work, doing big size work, you don't necessarily, if a lot of steps are slowing you down, I happen to slow down a lot for this kind of studies. There's some of them that you have to go through, but if you can like find these ways, find these people, and especially with the models that we have, with all these resources that we have, if you can like one thing that we can learn from this study would be how we can do big size multi-institutional work without going into all those ups and downs of and the struggles of legal and IRB and all of those things, and still have results. There are limitations, but sometimes it's better than not doing it.
Absolutely. Being in Canada, sometimes there's an easier path in sometimes the regional settings because there's more openness to sharing data and share, but the IRB always gets in the way. Well, thank you very much, Anna. Thank you very much for joining today.
Oh, thank you so much. Thank you.
Dream
Have a good
machine.
one.
Diacom HL7 IHE and snap. We're building the future, never looking back.